Let's look at what we heard from almost 1,300 health plans last year. This chart reflects the results of a survey of 1,275 health plans for our market trends guide, and it was conducted in December of last year. I think it's interesting and notable that both Medicare and Medicaid plans seem to be putting more attention on social determinants of health. What did surprise me is that housing and transportation didn't rank as high as some other topics like social supports, because I would, based on the literature, you're certainly seeing payers, put a lot more attention on housing and transportation as a primary focus. Let's turn a little bit to what some of the payers' responses been. I'm going to just touch on two payers quickly. United Healthcare and the American Medical Association sent out a press release back in April that they were working to improve identification of social determinants of health to help improve access and patient outcomes. And while these Z codes have been around for a while, they've put forth some recommendations that would develop a more granular set of Z codes. So they're Z codes with a decimal point that help further identify social determinants. For example, Z55 is a Z code that relates to the consumer having concerns or problems related to education and literacy, but they're recommending some sub-Z codes that would help break that out into more detailed information. So I think it'll be interesting to watch this. These codes are not finalized yet, the newer ones that are being recommended by the AMA and United Health, and it would probably not be until September of 2020 before they would be finalized and available. But it's really great to hear Bill at RHD say they're already looking at how they can collect this data and information to help inform. And I think as you think about value-based reimbursement, there may be ways over time to work with payers, because this is information that's very difficult, I think, for payers to collect. I know we would get eligibility files from our customers that would help inform us, who we were serving and what benefits we were managing. But often that information was very, very limited. Just, age and gender was probably the best data that you could get. So being able to get to more granular information, I think, is extraordinarily helpful. One more payer example on the next slide. Aetna and the National Quality Forum launched a Social Determinant of Health initiative to help identify quality and payment innovations. So Aetna is also working with CVS over the next 5 years and has put some significant dollars into evaluating how this can improve community health and wellness. And I think the Aetna CVS example and their coming together is also a great example of how you can open up access to the community. Just to give you a stat, 82% of Americans live within 10 miles of a CVS. So when you think about access to services, this can open up a whole nother realm. And then if you layer on top of that, Aetna's interest in really dedicating a team to focusing on social determinants of health and how they can insert that into their medical benefit is something I know that they're keenly focused on. So again, a lot of payer interest in this space. But I'm going to turn to Bill, who's going to tell you about a provider case study that touches heavily on information related to social determinants. So Bill, you can take it away.
Thanks. Just to give the RHD a little commercial, we were started in 1970, about 170 programs in 14 different states. We do just about every social service you can think about, except nursing homes and foster care adoption. We run 4 federally qualified health centers. We're going to start a birthing center soon. What we're going to focus on today is in 6 states, we house more than 2,000 people in supportive housing, scattered site supportive housing programs. And that's what we're going to focus mostly on today. Just to step back and look at the big picture, the United States spends 18% of our GDP on healthcare. That's about twice as much as other industrialized countries. Other industrialized countries do spend more on social services that do affect the social determinants of health and contribute to them spending less on their healthcare. If you think about it, 5% of the population, the super users, use 50% of the healthcare resources. So that means 5% of our population uses $1.8 trillion in healthcare resources, not food, not housing, not clothing. 5% of our population uses $1.8 trillion in just healthcare resources. And that's what we're trying to affect. We believe that if we can focus on the super users, bring their costs down, that all those numbers can change. We've done the research and we basically realized that, and you can find this, there's two types of super users. There's someone like me who gets in a car accident and I have 5 surgeries over the next 6 months, and a year from now I'm recovered. I'm no longer a super user. However, there is a consistent population that is a super user today, and they're going to be a super user for some time to come unless there's some type of intervention. And those are the folks who have unstable housing or homeless. They have a chronic medical condition, HIV, diabetes, hypertension, along with a chronic mental health condition and a substance use disorder. Those 4 things all contribute to each other and all exacerbate the other thing. And we also know that this population suffers from a serious history of trauma, which we all know affects their health. Now, we know that the one thing out of that whole group that we can affect tomorrow is potentially their housing. What we're trying to do is focus in on who those super users are who have housing, who are homeless. So we're trying to bring groups together, emergency rooms, inpatient hospitalization, managed care organization, and the offices of homeless services in various municipalities. People who touch all of those systems are target population for the pilot projects that we're proposing in various locations. One hospital that we've been working with has identified that 350 homeless people frequent their emergency room. Those 350 people have attended that emergency room 5 times or more in the last year, and they've either said they were homeless, they used the hospital as their home address, or a shelter in the city as a home address. And we found some interesting information from that. The hospital shared those 350 names with a managed care company. We stated that we thought these folks we made certain assumptions, and we found out that those assumptions were correct. They found out that the 100 top utilizers of those 350 people, their average healthcare cost over the last 2 years was $90,000. That does not include behavioral health costs, and it does not include pharmacy. So you could imagine what those health costs were to 100 homeless persons who frequent in one emergency room. What we're proposing is that we use that 100 top utilizer list as a target list to engage and house 50 of those people. Now we found out some interesting information about those people in general. Over the last 2 years, the 100th person on that list cost about $40,000 in medical costs. The 50th or median person on that list costs about $80,000 in medical costs. The most expensive person on that list averaged $622,000 in healthcare costs over the last 2 years. That was their average the last 2 years. We believe that if we just house that one person, that cost would go down from $600,000 to $100,000, and we could save the system $500,000. But I'm sure that every municipality in this country has a number of people who fit that category, that they're over $500,000 in annual medical costs. What we believe is that in general, if we can take 50 people off of that list and house them, that you'll see a 50% drop in emergency room care visits, a 50% drop in inpatient hospitalization, and a 50% drop in total healthcare costs. We have some small programs around the country that are doing this. There's some case studies that we've used. There's what's happening in Kansas City and in Massachusetts. In the Massachusetts study, they found that there was $2.37 in savings for every dollar that was invested in a supportive housing project to house super users. So that's a significant amount. Here's our financial assumptions for the 50 people that we're talking about. We believe that right now they're using at least $4.5 million in healthcare costs. And again, that does not include behavioral health or pharmacy. We believe that by housing those folks, having a mobile team go out to their apartments and check in with them so often, that those costs will come down by $500,000 to $1 million the first year, and another $500,000 the following year. Just to look at it another way, just one person, if their average costs right now are $90,000, if we house them, those medical costs will drop to $45,000. You would potentially add back in the cost of the mobile team that would go out and visit that person regularly, and the cost of the housing voucher. At a minimum, that person's costs are going to drop to $80,000. If you multiply that by 50 people, you come up with $500,000. Our effort is to, we want to underpromise and overdeliver. We believe that we can do the mobile team at a cheaper rate than $20,000. We can find housing vouchers, depending on your market, than cheaper than that. But we believe that we can actually save a lot more money than just $500,000. We've kind of figured out all these different components of the program. For example, we want to start using smart home technology, and we've already begun to help us monitor and communicate with people who are formerly homeless living in their own apartments. And we believe we can work out the evaluations. What the biggest problem we've run into is who's going to pay for the housing vouchers, because managed care can't use Medicaid dollars to pay for housing vouchers, or especially long-term housing vouchers. But we believe that it makes sense for them to think about it using actually other pots of money to pay for that housing voucher. But there are other possibilities. This is our kind of vision here. If you think about the social determinants of health, all of them, the ones that we can affect tomorrow are housing, food insecurity, and transportation. We're not going to change somebody's age. We're not going to change their literacy. Their social supports are going to take longer to put in place. But tomorrow, if we have the resources, we can affect somebody's housing, food insecurity, and transportation. And what we're looking to do in different places, depending on the market. Now, some markets, in terms of the housing market, if you're looking at San Francisco or Seattle, there's not housing available. There might be vouchers available, but not housing. In Philadelphia, there's housing available because we have a 9% vacancy rate, but there's not vouchers available. In different markets, there's different challenges in terms of housing. One model that we've been talking with many people about is getting community-based loans or loans from foundations to do the rental assistance and the housing, and then use potential savings to pay back that loan. And that's just one model. As Deb talked about earlier, there are MCOs who have seen the value of just investing in housing, and they're doing that in various places around the country, and they're seeing the results. So just to go back to the Kansas City study, they started with a pilot that with 22 individuals who were homeless, they were housed for 6 months. They saw a 64% decrease in ER use and a 38% decrease in psychiatric hospitalization. As a result of that, there's a coalition that's committed to put up 500 units of supportive housing in Kansas City for this population. Just to run through our little process map, how we would make this all happen, we would start with that engagement list of 100 people who are super users. We would As a homeless provider in different places, we have access to the homeless information system. So I can go into our HMIS system and put in somebody's name and see that outreach saw them at 12th and Chestnut in Philadelphia, and they were at this shelter last Thursday. So we can track these folks down because we have access to that homeless management system. Some MCOs are realizing that they don't have access to those systems, and their in-house care coordination teams are not successful with this population. And that's what we're proposing, is that we become that kind of mobile team or local homeless providers fill in that gap. We also want to have quick access when somebody shows up at the emergency room. So we actually do have people in emergency rooms at certain times